I'm Mercedes Bernada. I'm a pediatrician coming from Uruguay, and it's my honor and my pleasure to be here to introduce these very special professionals and in this last session of this amazing conference. I will ask Anna to introduce herself.
Good afternoon. My name is Anna Grachikova. I'm from country Republic of Belarus, and I'm really happy to be here and be with you.
Thanks. Well, and now we are starting our last session of this conference with a plenary regarding the managing of serious illnesses, children with serious illnesses in the home. For this, we have at first Dr. Renée McCulloch, who will present the care of the child with serious illnesses at home. Renée is a pediatric consultant in pediatric palliative medicine in the Louis Danda Center. She was Deputy Medical Director at Great Ormond Street Hospital and is at present honorary senior lecturer at the same institution. Thank you very much, Renée.
Not yet? Can you hear me now? Thank you. It's an absolute pleasure to be here today, and I wanted to start with honouring one of our colleagues who sadly died last year. And it's apt that we honour Spiridula, who was a colleague from Athens, who ran the home care team in Athens. And it's with sadness that Spiridula died last year, and our condolences are with the Greek team at Marymna. But I just wanted to say that Spiridula loved this conference, and she loved coming to work and meet people and get ideas. And she's a great example of the colleagues that we work with. And I thought it was very fitting that we honoured her in this session about home care. Not only that, she was amazing. She was the president of the Greek National Association of Paediatric Palliative Care, and she was also a transformational leader and worked on developing leadership for clinicians in Greece. So our condolences to the Marymna team, but we just want to celebrate Spiridula and all that she gave to our field. Okay, so I've gone a bit off-piste as usual, I'm afraid, and those expecting pain and symptom management might be a little bit disappointed, but I thought, when I started to think about pain and symptom management, I thought, actually, there's more to this, and you're all pretty expert on pain and symptom management, probably, and I think a 20-minute plenary is a real challenge to talk about that range and depth. So I thought, let's talk about the title, which is Managing Serious Illness at Home, and really thinking about the challenges that we face. And our team at Great Ormond Street have had the privilege of working as a team for about 38 years. So, we've become a regional specialist team, and it would be really amiss of us not to share some of our learning with you, perhaps, and think about how we support high-volume, medically complex, seriously ill children at home, and actually think about how we make a sustainable model for this work going forward. Thinking about our demographic, we have a demographic of children who move through these phases of care. Some are stable, some are unstable, some deteriorating, and then they become stable again. And they move through these trajectories until the phase of dying. And their diagnosis can happen at any time, at any point in any of these phases. And it's just reminding ourselves of the range of clinical scenarios that we can be dealing with at any one time. which is quite unusual, I think. I wanted to bring our team here to you, and I have got a 15-minute video, and I did think it's the Friday afternoon. It's kind of, we call it the graveyard session in the UK. Bit of irony there. But I wanted to bring the team to you, so I have got a 15-minute video to show you. But just to talk about the numbers of patients that we look after as a bit of background, and I just brought our statistics from the last 3 years, and you'll see that a third of our patients die in our specialist hospital, a third die in the local hospitals that we work with across London and the southeast, and a third die in the community, either at home or in a hospice. And when you look at preferred place of death, when we look at preferred place of death with our cohort, we could actually only speak to about 75% of our patients about where they wanted to die at the end of life. So that means that a quarter of them didn't get any choice about where they died at end of life, because it was impossible to give them that choice. And I know many of you will relate to that issue. And we don't do this work on our own. We have provider collaboratives and network established. I know that it's interesting because in the UK we have the National Health Service, which has less financial boundaries, although they are developing now, interestingly, in terms of regional finance and economic kind of change in our healthcare system. But our provider collaboratives have kind of grown from our right from the origins of when the team first developed, to think about, well, who can we work with to help to provide home care? And you can see that there's a real array of services here. There's the general paediatrician, who's the family doctor. There will be local hospital clinicians, doctors and nurses who we work alongside. There's the specialist teams who will always have input into many of the children we look after. Really importantly, we have children's community nurses who are able to work in the community, and they're often doing, many different things. They can, assessments. Some of them are related to more chronic long-term conditions, but some are very acute, general paediatric nurses. And then we have hospice services, and you've seen how we have about 50 hospices in the UK, and they have various services. Some of them are outreach services, and they will send teams out in the community, and some are inpatient-based. So a real range of provider collaboratives and networks established, and really no overt systems, and you'll hear that from the team. So when the team are talking in the video, you'll hear them talk about CAD pumps. Some of you may know about CAD pumps, but I put this picture up just to show you. It's a patient-controlled analgesia pump that is a mobile pump with a reservoir that we use between 50 and 200 mils in the reservoir. This is a patient of ours, Leah, who actually had AML, and we looked after her in the community alongside a specialist hospital near her for many weeks, actually. She had really complicated pain, and we had her on a methadone pump for that time and some of the symptoms. But when the team talk about a CAD pump, that's what they're talking about. So here's the video. Can you all cross your fingers, please? That we get sound. Thank you, Stefan. Oh, no sound. Can I pause it? Sorry. Can you hear music? Can you? Can you hear? Might need.
My name's Maggie Comack. I'm one of the AMPs on the palliative care team at Great Ormond Street. My name's Anna Chadwick. I'm a specialist registrar in paediatric palliative medicine at Great Ormond Street.
I'm Andrea Stevenson. I'm one of the CNSs on the Great Ormond Street Palliative Care team.
So I am Anne-Marie Harris. I'm a paediatric palliative medicine registrar at Great Ormond Street Hospital in London.
I'm Alicia Waldman. I'm a consultant in paediatric palliative care here at Great Ormond Street Hospital.
So I went to see an adolescent who has an osteosarcoma with lung metastases, who is at home receiving end-of-life care. So I tended to see the adolescent at home at least once a week because she had escalating symptoms, but actually what transpired over the weekend was a rapidly changing clinical picture. There'd been significant changes to the CAD PCA, so the pump that was delivering the morphine and midazolam. So my concern was, did we need to make some adjustments? And actually when I arrived, I felt that the clinical picture was actually calmer than I was expecting. We just spent some time unpicking the events over the weekend and just reflecting, and actually it's interesting, isn't it, because what I saw there wasn't what necessarily we get from on the telephone. I think it highlighted to me the importance of the home visits and actually then being able to talk through the clinical picture. And we have with the CAD the ability, we've managed to put a neuropathic agent, a benzodiazepine and a morphine into a CAD, which we can't generally do on a lot of the wards in the hospital. And actually the complexities of pain management, I think it's that multimodal approach. With the expertise with the pharmacist, with our CADs, we can really adjust the medication. Our goal is to manage symptoms, not sedate or not to give paradoxical medication. But the issue is if you've got a community service that only work 4 days, how do you manage that? So it's manageable, but it was manageable by having 2 hospices, having a community nursing team, having the local hospital came out and put a catheter in for me on one of the days. So I think it's wonderful we manage this, but it's a lot of hours and a lot of work.
We went to see a baby who was newly discharged from a neonatal intensive care unit, who was a premature baby, who was antenatally diagnosed with complex congenital heart disease. Their family had been given a life-limiting diagnosis confirmed by genetics. We had met in the neonatal intensive care unit, and it was to follow up from that visit once they were settled at home and to assess for any symptom and issues the family may be having. We talked around the generic things, starting with what it's like to have a new baby. It was the first baby to both parents, and how difficult that can be in the most optimal of circumstances, aside from then managing trying to juggle breastfeeding, NG tube feeding, as well as then in addition to that of having a life-threatening diagnosis and coping and living with that, which led us on to talking very briefly, which will probably need recurrent conversations later on around advanced care planning. And in the event of the baby becoming unwell, parents have agreed that they would want to seek review in hospital and have all reversible causes treated, in which we agree with that also, because currently the baby is incredibly stable. But these conversations were happening at the time when they were changing the baby, feeding the baby, and it naturally flowed in conversation rather than sitting down as you would do in a formal clinic environment. And it's recognising the importance of normal new mummy things in the context of having a child with a life-limiting illness and getting to grips and adjusting to that diagnosis.
Oh, I think before any home visit, finding out what previous symptom assessments have been done and any medication that the patient is on is useful to know. And then also establishing goals of care of that patient and family, thinking about has there been any advanced care planning discussions previously. I would often always think about, as well, is this a visit that needs to be done in conjunction with anyone else? So is it a visit that I'm happy to undertake alone, or do I think the expertise of one of our nurse specialists or a community children's nurse would be useful to collaborate and go on a visit together? And then it's also really helpful to have an idea of the social situation, so thinking about who has parental responsibility for the child and making sure that they are present on the visit, thinking about is there any safeguarding concerns or any concerns for staff on physical safety in terms of a visit. We also work as what we call duty doctors, so if our nurse specialists go on a visit alone, they can then call into one of the registrars and they will provide us with their symptom assessment, and we'll discuss through any medication changes that might need to be made, or if we think the patient needs to go to hospital for an acute review, or consult some of the other tertiary teams, for example the oncology team that might be involved in the patient's care, about ongoing next steps in their management.
So I think the first thing to say about doing a rapid discharge is that it is a team approach. It's really important to acknowledge that there's so many kind of moving parts to be able to do that process. And by rapid, we hope to do it quickly, but we need to do it safely as well. So those are the two kind of key things we think about to begin with. Initially, that will start with having conversations with both the current team where the child is, and then looking into the community and about what provisions are available for them, particularly if they're going home, working out what home looks like, and making sure that we have all the options available to some degree before we go to the family to be able to explain those further and sort of say, you know, this is what it looks like for you to take your child home, and we can support in these ways. What are your thoughts? I think following on from that process, it's really helpful to have an MDT meeting to put everybody together to make sure everyone's on the same page about what the clinical needs of the family are, what the psychosocial impact will be about taking this child home, and the practicalities of transferring them and what that looks like in terms of managing medications, for example, equipment, the actual transport out to home. That will be adaptable to the clinical scenario, so it might be that we take children home who are ventilated, for example, and they're going home to be extubated. But it might also be that children don't have those kind of complexities but are going home and still need a level of supportive care that is quite intense, that we need to make sure the community teams are able to provide, along with the specialist palliative care support that's given face-to-face through visits, but also out of hours via telephone.
Our palliative care service has a phenomenal service where we offer 24/7 on-call support to parents and families directly at home, but then also to hospice staff or to other healthcare professionals, both in Great Ormond Street Hospital, but then also across many hospitals throughout central London. I can think of many conversations that I've had with families as their child has been actively dying or having incredibly complex symptoms. And I can recall one not so long ago, actually, where the child had a background of a cancer diagnosis and had been slowly deteriorating at home. And parents were very clear that their preferred place of care was home, but their preferred place of death was hospital. And we have lots of discussions about what the right time was to move, and it was really difficult to ascertain. And when I was on call one Sunday afternoon, he did acutely deteriorate from a respiratory perspective, and it became quite apparent that he was actively dying. And the family were very fixated that they wanted him to not die at home for the impact that it would have on them as a family and on his siblings. So we then utilised London Ambulance Service, who came out and recognised that it was out with their usual scope of practice, so that we actually then were able to move him to hospital to facilitate the preferred place of death. And I think in those situations, it's really about clear and honest communication with the family. And that was a difficult one because I'd never actually met the family before in person. So it's trying to establish that rapport at probably the most difficult time in their life. And have really honest and frank conversations about the risk of him dying en route to hospital, and make sure the family were aware that that was a real possibility, and how we would manage that moving forward.
I've been here for almost a year now. Most of my career prior to this was in the United States. Everybody asks me, both here and in the US, what's better, what's worse, what's right. You know, it's very different. One of the respects in which it's different for me is that we do a lot of community-based care here, including home visits. And that's very different from the US, where we have partners out in community-based organizations, but there's typically, while there's communication between the hospital-based team and the community-based team, they're different. Frankly, I don't think I've been in a patient's home in years in the US. There are a number of things that are really terrific and really important about doing those home visits. You know, so often in the hospital, particularly in the intensive care units, we meet our patients at their worst. We often hear in intensive care units, what are we working for? Is this really in the child's best interest? And that sort of thought process, which I know comes from a very good place, but when it's colored through the lens of seeing a child at their worst, that may not be the most accurate thought process. You go visit those families at home, and often you see a child who is utterly transformed, and parents as well. And when it comes to helping families navigate decision-making and serious illness, and helping the children themselves navigate it, understanding who they are in their own contexts, right? When they're at their best, when they're comfortable talking to you, when they're able to show you, this is what my room looks like. This is what I like to do when I'm feeling better. I mean, when you experience that, you realize that trying to do that just based on the hospital setting is really doing it with one eye closed, right? And sometimes that's all we've got. But it's important to recognize that, the same way when we close one eye, our depth perception is off. We're not really seeing the full richness of the full picture. So the flip side to all this, now that I've sung the praises of doing home management, in the US, where most care is hospital-based, everything is very much under my control, right? So when I am on service, I know exactly where all the kids are in the hospital. I've seen them all during the course of the day. I know exactly who's on in the hospital looking after them. And so when there are changes at night or on the weekend, when things are dynamic, it's not such a big leap for me to say, oh, I anticipated this. Let's give X, or this is what the family was thinking today. Let's respond with Y. Here, the flip side to that is, I often find myself, especially if I haven't yet managed to meet this family at home, I often find myself providing advice at off hours for a child I may not know well, if at all, in a setting that I don't know at all, through community-based providers who I might not have met, and that can be deeply unsettling, especially when we're talking about the sorts of decisions where you have to ask yourself, is this the family that wants to go to a hospital for review and they might want an intervention? How sure am I that this is not something serious and it's a family that just wants to be at home? How aggressively am I going to treat this symptom in the middle of the night when I don't really know this family or the people who are there doing the evaluation? That can be really, really unnerving. It's a real double-edged sword. Again, it's not about one is better or worse, it's just very different.
Well, I think that really boils down to the fact that we want to be able to offer families the choice of where their care is delivered, so that they can be in a place that feels safe and secure for them. And it's all about talking with patients and their families about what their preferences are, understanding what motivates them to be in a place other than the one they're in at the moment, and working out what that actually looks like in practice so that we can support them best.
For me, why it was so important was it was her preferred place of care. I very much think wherever their preferred place of care is really, really important, even if that is in hospital, that's their preferred place of care. Her mum said to me on the last day when we were sitting just having a cup of tea when the home visit, and just saying, I can't change this situation, but I take some comfort knowing that her wishes were respected both along the journey and at her end of life.
So, I hope you found that interesting and get a sense of the work of the team, and I'm sure many teams have a similar experience. But I think it's going back to the roots and horizons. So, home-based care has been rooted in doing the right thing, and it's what families want. And as Alicia said, it gives us a different perspective, and families value that, and we know how important it is to communicate well with families and align with them. And we do that better when we are probably in their own home on their terms. Actually, when we think about, there's a really nice paper from Canada here about thinking about questions to help decide place of death. However, there's so much decision-making complexity these days that so many of our patients are not deciding place of death when they're going home unless they're going for end-of-life care and their child has clearly declared that they're dying. Most people are choosing place of care, not place of death. And actually, I reframed some of these questions to think about what we need to think about when we're taking a child home for care. Are we competent and capable to deliver that care? What's going to be the impact of that, anticipating what that child needs? Have we got that right? Have we checked out their location? Is it safe for them to be looked after there? The child that Anne-Marie was talking about, we ended up having a real difficulty getting that child out of the 18th floor because the stretcher couldn't fit in the lift. We really need to think about that. Have we got a sustainable workforce? We've talked a lot about workforce, but actually we're always doing this, as Andrea, our nurse specialist, was saying, just boxing and coxing and trying to do our best and trying to get that safe care around the child. What safeguarding issues are going on? We mustn't forget safeguarding. These are children, and are we doing the right thing for the child as well as the right thing for the family? Medication pathways. We see so many medication errors in community care that we are hawkish about medication because we've seen overdoses, issues about drugs being delivered at different concentrations, so many issues. And we're responsible for that. We're also responsible for training on equipment and thinking about infrastructure coordination. How do we get a death certificate for a child who's, 200, or an hour and a half away on the train from us? So you really have to think about operational risk. Just very quickly, because I think I've just not estimated my time correctly. I think I might have started a little bit late, she says desperately. Thinking about what safe care at home looks like, and that's what the message from me to you is today. Are we transporting these children in the right ambulances between locations? This is our risk assessment for our CAD pump. When we put our CAD pump up for 48 hours, we've risk assessed that to make sure if we don't have someone to change it, can we run it? Have we got the right volume of drugs? So many things. This was the medication errors. We looked at over 9 months of our patients, and we collected datexes for all our patients, and 57 of them had 58 errors reported. Some of them were parents administering drugs, and actually it's really difficult for parents to be part of an error, something that's gone wrong in the home. But actually, is what we think safe what parents think is safe? There's some really nice work that's been done, I think, out of Ohio, which was looking at what parents think safety looks like. And actually what we think safety is different to what parents think safe is. So are we prepared to make a compromise on what safe care looks like if we're taking children home? Our benchmark is that we're not really prepared to compromise symptom management. So if that child's got a central line in and we know they're going to have challenging pain, we won't manage them on a subcut pump because we think doesn't meet our standards. We've talked today in various different talks about what parents value: symptom management, psychological support, care coordination. They're all really important. But what are we noticing about symptom management? We're noticing really high morbidity of care for very long duration, increasing complexity, multi-location care, and we are taking responsibility for that care. And actually, we're really good at this kind of stuff. We can keep people at home. We can do chest drains, pumps. We can manage when somebody has feed intolerance or GI irritability at home and they can't be fed. They've got really bad dystonic or epilepsy, dystonia or epilepsy. We can manage that, and we're good at it. But should we be doing that? Because actually, symptom management assessment, anticipatory planning, advanced decision-making are cornerstones. It sounds easy, but it's really not. We're expecting parents to assess and be able to translate that into something that we can understand on the phone, to be able to intercept. It's often a skill that's really difficult. And if we as teams, consultants, are taking responsibility for this community care, in order to trust the system, we have to train the system. We have to listen and learn and keep moving. But this is a real challenge in our modern day, that actually as consultants, we're taking responsibility for a lot of complexity. We've talked about challenge to home-based care across the board, so I won't go over that. But, there's so much risk that we carry. So horizons, okay, we need to decide who we are, because sometimes palliative and end-of-life care is straightforward, but managing really complex illness at home, often without, advanced care plans in place. What is that? Is that symptom care? Is it enhanced supportive care? Is it medically complex care? Is it seriously ill children? Who are we? What do we do? Because if we don't know, it's really difficult to tell policymakers and define who we are and what we're going to be delivering. So really, we need to formalise our care models and standards to deliver really high-quality care, ambulatory and home-based care. And it has to be evidenced pathways. And we need to think, really, what does safe care look like for us, for the families? How do we get that right? We need to evaluate with outcomes, as we spoke about this morning. We need to make sure we have equity of access, and we need to make it cost-effective, so it's care for all. And actually, we've talked about national, regional, international collaboration on what those care pathways look like and those standards of care. So thank you, and I'm sorry that was a bit of a rush at the end.
Thank you very much, Renée.
Okay, our next topic, it is support for family members and strategy for engaging in a community. And I want to invite Ulrika Kreicbergs. She is a professor and chair of palliative care for children and young people at Great Ormond Street Institute of Children's Health, University College London, UK. Welcome.
Thank you, Anna, for your introduction. Renée, how did we get it going?
Yeah, it should work like that.
Oh yeah, okay, but we should go back. Yeah, so I'm here to talk about the care in the community, and Renée gave a very nice kind of introduction of that we need community care to be able to care for all these children at home. And so what is the community, and what can we also learn? I'm thinking of what Richard said this morning, that we can learn from the adult care, and that we can really learn from them and they can learn from us. I think they have a lot to learn from us, but we can also learn from them. So this is a very nice report from Libby Selnov, who I actually invited to take this talk instead of me, because she has the skills and knowledge of talking about the community services in pediatric, or in palliative care, I should say, mainly adults, but we can make it ours. And she also talked about bringing death back to life, and I think that's what it's all about for us. And seeing dying as a social and spiritual process rather than a psychological or physical event. We have to bring it back to normal, and we have to have a support network to care for these children, and we have to recognize as it has value, and we also have to communicate about death, dying, and grief. I think that is very, very crucial. I think it's been so much about communication during this conference. It started with a very nice pre-conference with Dr. Baker, who is here somewhere. And it takes a village to raise a child. That's an African proverb that we can also say it takes a village or it takes a community to care for the seriously ill child. And that's what we are here for. And we also heard about in the movie that Renée was showing that it differs in different countries, and we are unable to explore and report from all the world, which I would like to, but it's not even studies from around the globe, so bear with me, but I would like to present some different examples from at least 2 countries where we can see the difference. And what can the community do to us in pediatric palliative care? Do we need their services, and how can we improve our services by involving the community? So this is a study that is from Ireland, and Ireland is one of those countries where they have excellent home care, and a very, very high percentage of children have been seen by the community nurse, and they called clinical nurse coordinators, and they were involved in 88% of the children's care. And this is a retrospective study of 77 children over a 7-year period, if you want to read it. And the specialized palliative care team was also involved in 87% of the children's care. So it's vital that we use the community care to provide the best support for children and families at home. And then we have a study from the United States where it's not so common, as we heard Alicia say, to have the hospices and home care involved for these children. And this is a 1-year review from California in the United States. And it's only marginal numbers of children that have had their the offer to go to hospice or to go at home. You can see it's only 18% that could be referred to home. Although this is a much larger number of children, because California, as compared to Ireland, is a huge difference. But it's a lot of missed opportunities for these children and families to not have the opportunity to have hospice or home care. And what do I have here? I can hardly read from that slide. It's very difficult. Yeah, so it's about the communities. Where are the communities? And living the world online. So this is examples of children and I would say young adults and adolescents. And they can actually have their community online. And all these children in this study was children with cancer. And I have 3 studies here, and this is another one with only cancer patients involved. And the studies have a mixed method approach or just qualitative work. And the last one is of children with more life-limiting or life-threatening illnesses. But they are really appreciative of the information and the emotional support and the feeling of normality or normalcy that they can get with their friends online. So we shouldn't, we should really encourage them to have their kind of place to be. And I remember seeing a TV show in Sweden. It's led by a Norwegian guy, and it was a father who had lost his son, and he was there talking about it. And at the end of this son's life, he said he was only on his computer like all the time, and he had been ill for many years, so he had lived his life in his room with his computer, while the family was very, very busy taking care of his sister, who was playing handball all over Norway, running and traveling with her around the country for the handball. And when this boy died, it came people from around the globe to be on his funeral, because he had such a community online. And they didn't know. The parents didn't know. They thought he was all alone in his room. So it was so touching, I thought. Yeah, so he really had his social belonging in the community. And also bereavement care is something that often happens in the community. I mean, Renée has talked about the specialized palliative home care teams, and we have the specialized home care teams have a very special knowledge and skills at some time in the child's life and during the disease trajectory. But in the bereavement phase and following the loss, we at the Great Ormond Street, they always have a follow-up, so they meet the bereaved parents, they try to at least, but then it's often offered online. And this is for teachers to help the children who have lost someone to get support in school. And I think it's so much we need to start with the children in school. So the teachers need teaching in how to meet and kind of take care of these children and their feelings. And this is another study with some, it's just a tiny number of families, but they really explore how the community have had an impact on their life, whether they had a stillborn or a neonate being born, where no one else have met the child, but they had their friends in their community that could understand their situation and was there for them many, many years after their child's loss. Yes, and this is a very, very nice study, I think. I think this is like the future. It's called the Last Aid Course, and it's been around in over 21 countries in Europe and in Australia and US. But I have not heard about it, and it was only one study that I could find that have been doing the Last Aid Course for children and teens. And you can see here that it's almost 3,000 children that have had this course, and about 2,500 also responded to how they perceived it. And the course is with these 4 different domains, and they have a different program that goes for the children, mainly in schools. So you can see the age of the children, and you can also see how they perceived to be in that course. They really acknowledged being there and thought it was very good or good to be there. And 91% of these 2,500 children said they learned something new. And I think we need to start with the children in the school age to bring the awareness about pediatric palliative care. And the way the world looks like these days, it's so much grief, it's so much dying, it's so much illness and suffering, not just only to illness, it's due to other causes as well. So I would promote the Last Aid Course for children and teens. And I also would like to show you a short movie from those who work in the community with our patients at the Louis Dundas Center. It's only 5 minutes.
My name is Susie Palmer. I am a children's community nurse based at a local trust. Within the community nursing team, our role is to support the symptom management palliative care service. When a child has had a poor diagnosis, our role is to support them in the home environment. We support pain management, we support play therapy, we try to support the families as much as possible, just to give them somebody to talk to. We make sure that the medications are in the house, that they're given safely. Children feel more comfortable in their own home. So it's important to have the service and be able to offer the child and the family a place where they feel secure, where they feel comfortable and supported in the end-of-life care. Generally, the challenges that we come up against is if we are trying to support a family at home over a 24-hour period, day, night, weekends, 7 days a week, staffing levels does seem to be the main challenge. Support from local trusts has increased now to be able to support children at home, but that was a big challenge before now.
I'm Hannah, and I'm a palliative care nurse specialist, and I work between Noah's Ark Children's Hospice and Great Ormond Street Palliative Care Team. The purpose of my job is to act as a link between the two organisations to support families so that they have consistency, good communication, and that we're working together really effectively to make sure there's a smooth path for families and that they can make meaningful choices about their preferred place of care and death. Our hospice supports children with life-threatening and life-limiting conditions who aren't expected to live beyond adulthood. And we provide a range of holistic and clinical services to give families support from diagnosis through to throughout their treatment and beyond. We focus very heavily on holistic services. So in our hospice, it's the Family Link team that goes out first and meets the families and asks them, what's important now? What matters to you as a family? And sometimes that's clinical things, and they have clinical questions, but more often than not, it's about things that we as professionals might not identify. It might be, I'm actually worried about my other child, or we can't pay our bills at the moment, or actually we really want to go swimming and we can't. Can we try your lovely hydrotherapy pool? And we'll obviously support with short breaks at home or at the hospice, and then we can provide symptom care and end-of-life care either within the hospice or at home. The way I would describe hospices like ours to families is to say that it's a menu from which you can choose. We offer a range of services, and some families just want one or two things from the menu, and other families want the whole package. And we're family-led, so anything is fine, and we work from the family first, and we build the support around them that they need. Our hospice provides care in the community. In fact, we were a community service before we had a physical building. And in our experience, when we look at all the families that we support across the hospice, the majority of families choose to remain at home. That is their preferred place of care and death. So actually the majority of the care that we provide from the hospice is in the home. So the hospice is really part of a whole sort of ecosystem working around children and families. And we work really closely with the Children's Community Nursing team. And where there is a specialist children's palliative care team in the community, then obviously we work closely with them too. So we form a network around the family so that they get what they need when they need it, particularly for those families who choose to remain at home for end-of-life care. And we work together in a synchronised way to make sure that families have support 24/7, particularly if they need support at end of life. And it's really important that we work together effectively, that we don't overlap, that we aren't competing, that the family feels not overwhelmed, but the teams are working together in a really joined up and effective way. And part of my role is trying to streamline that. So actually what families experience is seamless care from one team that gives them the support that they need when they need it. Part of the support that we offer through the hospice to families is working really closely with the Great Ormond Street Palliative Care team, which is the tertiary service in our area. And they provide that oversight, the guidance, the specialist knowledge and insight, and the team of consultants and CNSs and psychologists and social workers that works in a very holistic way around the family. And then as a community service, we then deliver our support with their guidance, but also we're passing information back and forth, which allows them to then make decisions about how they manage symptoms effectively. So it's really important that we all work closely together as the tertiary service, the Children's Community Nursing team, the hospice, communicating effectively together to provide the best care.
And then I would like to engage you and know who you are. So I don't know whether this will work. I had organized a Mentimeter to see how many of you are working with the community services and how you engage with the community services. So let's see if we can get that to work from our technology part. I think we haven't been involved enough. So we need to know who you are, who are here. At least I'm interested. No, it's not. Could you get that going? Maybe it's not working. Yeah, here it is. So who are you? And you can just check in there. You can see jointhementi.com, and then you press that code and you have the questions. It seems like it's predominantly physicians here today. Or maybe they are the quickest to get the Mentimeter going. We have no pharmacist, no chaplain, no physiotherapist. We have 40 nurses and just twice as many physicians. Yeah, it's still coming in. Very interesting to see that we have this variation and we can build a team of those who are here. I like it. We should go on to the next question. If you just press the button, or if I can, let's see. No, I can't. Could you please help me? Yeah, they have to do it from up there. You just go with, yes. So what do you work in? You should have the next question. Yeah, it's fine. Mainly it's hospital physicians working with some nurses. We have a few, half of you are in home care, yeah? And we have the academia and we have hospice. Yeah, it's a great representation. We take the next question, please. Can you get the next question? Is it possible to get the next question? No. Can you go back? Yes, so here we have the third question. It's only 4 questions. It's great to see that so many are working with the community services. That's good for our children and families. Thank you very much. And now we take the last question. Could we please have the last question? So what community services do you utilize? And now you have to type. And you can use 3 words. So it's community nurses, nursing, primary care, hospice. So I think you've done well. You passed. And it was nice to see who the audience were, and I'm very happy that you responded to the 4 questions. And thank you for listening, and I'm very happy to be here for, I think, the 6th time. And yeah, I'm very, very lucky to be part of this organization. And thank you to all of you, and have a safe trip home today or tomorrow. Thank you.
Well, and now coming to the last presenter, I'm very happy and honored to present my friend, Dr. Ricardo Martino Alba, who is the head director of the Pediatric Palliative Care team of the Hospital del Niño Jesús in Madrid, Spain. And he is as well the director of the Centro de Atención Integral Paliativa Pediátrica in Madrid. Well, he is going to talk us about end-of-life care. Thank you very much, Ricardo.
Thanks. It's difficult to add any more to this presentation. I will try to share with you some reflections, experiences, or topics which are useful for our daily work, and I hope perhaps can be helpful for you. I don't will explain this dia, but Maria in the morning has explained we are organized. Why we are going to speak about home care at the end of life? The answer is very simple. Natural place to live is the home. The natural place to die was also the home. But in our developed world, patients with greater clinical complexity are treated in hospital, and it seems that the best care can be only provided in these hospitals. But to receive home care is a matter of the quality of care. The goal of any healthcare system would be to provide the best care to the patients so that the patients and professionals are satisfied. Pediatric palliative care we used to define as a way of providing person-centered care, and the involved persons are patient, family, professionals, and caregivers. Everybody suffers, but our patient is the first one as goal of our therapy. If this type of care is provided during the patient's life, it should continue in the same way as they approach the end of life. But for us, it's also a matter of ethic, moral, and in bioethical reflection. We can say it's a matter of justice to give each person what they need, non-maleficence, avoiding adverse events or hospital-acquired conditions, beneficence, seeking the patient's best interest, and a matter of the autonomy, following children's desires, allowing the child to be with loved ones and engage in activities that are important to him. To ensure children live as well and as fully as possible. How we can do this home care at the end of life. I have organized in 5 steps, but it could be 3 or 10. It depends on the speaker. To diagnose, to communicate, plan the care, provide the care, and evaluate the care. Diagnose the end of life. how we can diagnose the end of life. We can observe signs, symptoms, and a change in the patient's baseline in the clinical trajectory. We have to communicate to the patient, the family, the other healthcare professionals. We have to be honest in prognosis and explain the dying process. But this is very useful for the families. They're suffered with the consciousness, the noisy breathing, and to explain the way of dying can be helpful for the family, but cerebral hypoperfusion can be good for the patient's dying process. To plan the care with an appropriate decision-making, advanced care planning, with scheduled visits, adjusting the treatments, anticipating possible emergency situation like Maria has explained today, and considering aspects of hydration and nutrition, but these are very important aspects for the family and the care for the child. We have to act to provide the care. Family has expectations with our promises and with our planned care, and we have to fulfill this care with a scheduled assistance, telephone calls, the emergency care, and if possible, also be present on the death. To make dying at home possible, palliative services must be able to guarantee all necessary types of care, and it's essential to have a team. And it's good to evaluate whatever we have made for each patient in each case. We made a continuous evaluation because of the patient guides our action. We have to hear and to observe the patient, and the patient give us the answer to our questions. And it's also to evaluate after death with briefing sessions to assess the team's performance, to learn from success and mistakes or failures, and to release also and share emotional burden in the team. Patients and the families are mainly concerned about suffering. Therefore, the most important thing to make possible a good home care at the end of life is an adequate symptom control. And families expected that the child can be quiet without pain or without vomiting. If suffering is a conscious experience and most patients fall into a coma before they die, they will not suffer during dying process, and this will a good news for the family. In other cases, sedation is an option. Sometimes families and professionals have difficulties to accept some measures or the withdrawal of some measures like monitoring, hydration, nutrition, or the oxygen supply in the agony. We try to retire the oxygen supply in the agony routinely. And the professionals. To deliver home care is a challenge for professionals, but we have to step out of our comfort zone. We are in risk of emotional attachment, and this can be a burden for us. We train consciously a sufficient emotional distance with patient and family to be able to do a good decision making with objectively and not falling also in therapeutic obstinacy. but there are some survival rules. Patients and family often make statements to empathize. You are my family, you are from my team, but survival rules are, we are not a family, we are not a team, and if he would be my son, I would not be his doctor. These are frequent topics that come in our conversations. When is not the most important thing, and we change the focus not in when will the child die, but the most important thing is how. But if we are able, it's good to anticipate the process and the moment in order to allow the family to come or will be together with the child. The how is our responsibility. Our work is to allow a good life and a good death for this patient. To die well or to die with dignity means to maintain the value as human being. We used to say, so as minimal conditions to die clean or well cared, to die accompanied with loved ones, to die pain-free or under symptoms controlled, and if it's possible, to die conscious, living the moment. Where? Home care. This is our responsibility. Ensuring a good life or a good care determines the place of death. If we can provide this care at home, the patient can die there. The goal for the patient is not to die at home. The goal for the patient is to die well, if it is possible. Families feel alone and powerless in coping with the situation. They want specialized, competent medical and nursing care available 24/7 with access to psychological, social, and spiritual support. Sometimes it's not possible. If there is no available house or a home, if there are no competent caregivers, if there is no home care in our organization, if there is no 24/7 care possible, organized by the primary team or in a good network, or sometimes if the parents are in conflict, we have to evaluate the situation. Perhaps it's not possible to die at home. The evidence available does suggest that access to nursing and medical care 24/7, staff with specialist knowledge and experience in pediatric palliative care, effective symptom management, and partnership working with a range of disciplines and service are key elements of any home-based end-of-life care service. Any palliative care service that wishes to provide end-of-life care at home must be able to guarantee 24/7 attention by a specific, trained, and competent team that can meet the needs of the patient and the family. Thanks.
Thank you very much. Sorry? Yes.
Some questions. Now we have time for questions. Maybe you have some question for our lecture? Please. No questions?
People are tired.
People tired, yes. A little bit.
There's some.
Okay. Please.
Hi. I'm coming from France, and I was at a poster session from, it was a poster from your team that was presented on the home palliative care before and after opening a pediatric palliative care unit in Spain, and how having that kind of unit helped have more home deaths. I was wondering if you could maybe elaborate on that experience.
I haven't understood the whole question. What do you want? I'm sorry, but my brain is exhausted at this time of the Congress. I'm sorry.
It's the end of the Congress. I'll try again. So I saw a poster from your team today where they presented results from accompanying home deaths, but before and after you opened a pediatric palliative care unit, or the 6-bed unit where you were, but specifically dedicated to pediatric palliative care patients. I was wondering if you could share a bit more about this experience, about how having a pediatric palliative care unit helps your home care.
Yes, we have, our experience is shorter than in GOS, but we have also 500 deaths at home we have accompanied. And before we started to work, all the deaths occurred in the hospital. And we have observed also the curve, and now most of deaths occur at home. We, in Spain, home care will be delivered in pediatrics mainly from the pediatric palliative care teams, but pediatricians usually not go to home to take care. And in the last 10 years in Spain, we have created and developed more than 50 teams in different types, locations in Spain, and this has changed the home care.
I have an observation and a question. It was made clear, and everybody here knows, that the States, where I'm from, has originated the palliative services from the hospital base and has difficulty reaching out into the community. Whereas the model in the UK and Spain and elsewhere is from the community inward often. What advice would you give my colleagues who are trying to consider the development of an outpatient service? They are comprised of 4 board-certified pediatric palliative medicine doctors, half a dozen nurses, 1 social worker, as of yet no psychologist. They utilize the psychology services and chaplain services in the hospital. But I know they would ask you this if they were present. How would you direct us?
In Spain, the Spanish model of pediatric palliative care is a mixed team based of hospital with and home care with the responsibility in the hospital. So and home hospitalization. This is our developed model, and all the teams in Spain try to give care the same patients in hospital and outside. Our psychologists, social workers, chaplain goes home and give support in home care attention. They no stay in hospital. We as doctor, nurses, we go to give the medical attention, but they travel during the whole community and have their own schedule to visit the patients, to give support. The same team, also social team, works in the hospital and also in home, the same team.
I would say do nothing until you have funding. Think about your capacity, think about your well-being, think about what's achievable. And I think that we have to start to think differently. I was chatting to someone at lunchtime about, I do a lot of work with younger clinicians, doctors, nurses, psychologists, and thinking about what that workforce looks like. And a different generation, different expectations of how to work. We haven't necessarily done things in the right order, and it doesn't, home care is important, and I suppose this is one of the things I was trying to talk to. It requires intensive and considerable workforce to deliver it well without carrying too much risk for the families and the caregivers. So if they are going to do more with the same resource, I would be very wary of that.
And in the U.S., risk to the family is considered, but also risk to the team members from the standpoint of managing risks, avoiding legal ramifications. So I'm hearing build the team large enough, well enough, resourced enough before you leave the hospital. Is that a fair estimate?
I think there's something about activating the network. There's something about what work can we share, what work is specialist work, what work is core work for clinicians who work with children and families with serious illness. We need to start thinking differently. We need to start thinking in terms of perhaps specialist pathway models. Cardiology may be a different pathway to cancer. Cancer's the easy one. We can prognosticate with cancer. Metabolic conditions, neurological conditions, additional support that is often required with intercurrent illnesses with Optiflow or Vaportherm is chosen in hospital. So we have to map out these pathways, think about actually what is our standard to deliver care. These are not end-of-life care pathways often. They are the care of children with long-term complex conditions in the community. And we mustn't break our teams. We need to treat them with respect. We need to be thinking about what the generation coming after us will consider. There's a lot of trailblazers in the room, and I would just say, we have to work to live, not live to work. And a lot of people have dedicated so much of themselves to the work. Sustainability and workforce is really important. And that speaks to safety of the patient as well.
My last question, can they come visit in Spain or London and
Very
learn
welcome.
on the fly, spend a week to 4 weeks with a team?
No, I don't. No, say?
You can come to London. You're welcome to London.
No, okay. Sí. We are a very kind team. Madrid is a very good city, and you are welcome if you want to visit us. We are open to everybody, and so as a touristic destination, our word and our team can be an option for some professionals. No, welcome to us, please, and we can show you what we have. It's not perfect, it's the only thing we have. We try to develop pediatric palliative care networks, but we are on the way. We have started from hospital 2 outside, but community are not sufficient involved to assure the care at this moment. In the future, we try to develop better networks. In Catalonia, in Barcelona, there are more advanced to develop a network because this is a great territory. And in Madrid, we can make this in some way, and in other parts of Spain, it's not possible. And we try to develop the appropriate networks for each land. Thanks for your interest, and I'm sorry for my delay.
Stefan? And afterwards me. Okay. To Ulrika.
Thank you. Stefan Friedrichsdorf from San Francisco. Another great example how different things are on different sides, on different continents. And I think here in Europe, this is such a strength and such a wealth of palliative home care. We know from Poland, we know from Belarus, who since the very early 1990s and then at the same time in the UK, started to see most children at home and have programs which are like huge. And Brian, to talk to to my knowledge, the only palliative home care program in a hospital is in Minneapolis. So they have done this for 20 years. So it's doable, where a children's hospital basically owns the pediatric hospice. And it's so much cheaper than having a house. Yeah? So, and you can take care of so many more children at any given day than investing sort of in the brick and mortar. So I think just supporting the idea, I'm applauding all of you of providing such amazing home care. And at the end of the day, most children want to be at home most of the time. Not all of them. But if we have the opportunity to provide those services and invest into nurses, into social workers, into child life specialists, and into doctors who can get out there and other interdisciplinary members, we provide so much better care. So thank you for this amazing session, and to inspire all of us to really make sure that we are investing into palliative home care, into palliative hospice service in our community.
A short question and last question perhaps to Ulrika. I would like you to expand a bit. What are the key points of the impact of that course you mentioned at school, for children at school, and in which way that may contribute to the creation of a palliative care network, community network?
I mean, as far as I know, the aim of the Last Aid course is to bring awareness and literacy about illness, death, and bereavement. And it has been going, as I said, mainly among adults, and it has been provided in different venues to society to improve that. And for this German study, they provided the different 4 themes. It's movies for children to look at, and it's discussions, and they really, as the title says, they really appreciated to being able to have these existential talks
about what is value in life and death. So I think it's something that we really could contribute to, and it would benefit not just our kind of pediatric palliative care community, it would contribute to humanity, I think. And I mean, bereavement is around us everywhere. So I think it was very brave of them to do it in Germany, and I would love to do it in whatever country I be in, to have this as a more like a value, like what do you say, like a social experiment, so to say. And it was barriers, of course, and the main barriers were parents and teachers. In every session, it was always someone that had been working in palliative care present, together with the other kind of interventionist. So it was really grounded with people who knew what they were talking about. And I know we have one participant here who has been doing this in Lithuania. And I don't want to put him on the spot, but if you would like to, you could just say a few words, because I was so happy to hear that you were doing this as a pioneer. If he could just have the microphone.
Yes, hello everyone. My name is Ivan, I'm from Lithuania, and I'm a pediatrician. So George Bolik brought to Lithuania last aid in 2019, and since that time I was doing it for like a couple of tens of times with different people with no medical background or with medical background, and each time it was very emotional, with deep impact on those people who attended this course.
Sorry. If there are not more questions, we will finish this session, and to allow the responsibles of the closing ceremony. And thank you, all of you, very much, and all of the attendants. Bye-bye.